Hello guys, Assalamu alaikum. I'm Dr. Asif. Welcome to my channel, Medical Tutorial and Surgical Blog. So now I'm continuing the video that is MRCS study with me. It is the anatomical topics related with thorax. As you know, that I have been doing these lectures for a few days. So this is the third lecture of from anatomy. So it's a little bit smaller than the other anatomy lectures. So there are some few topics that you need to know from anatomy or anatomical knowledges. So there is first you must know about the mediastinum and the sternal angles, trachea, esophagus, along with their relationships. Then lung anatomy, phrenic nerve, and their distributions or course. Then thoracic duct and their distribution with course. Then heart anatomy, heart related things, superior vena cava, that is great vessels that lines here, and the vena cava, then thoracic aorta is also containing some vessels and some heart valves and the x-ray. Let's start. First, the mediastinum. What is mediastinum? That is the reason which is necessary to know the region between the pulmonary cavities. So in between two lungs there is a space where heart and the great vessels kept lying on. So in that space is called the mediastinum. So it is covered mediastinal pleura. So it is a covering. So that is mediastinal pleura. It does not contain any lungs. It extends from thoracic inlet superiorly to the diaphragm inferiorly. Okay. So above the superior and the diaphragm inferiorly. Okay. Now the mediastinal types, that is superior mediastinum between the mandibular angle and the LT4 and 5, and the middle mediastinum, posterior mediastinum, and the anterior mediastinum. So this is the anterior mediastinum here. If I this is the anterior mediastinum, this is the middle mediastinum, both areas middle mediastinum, this is the posterior mediastinum. Okay, so this whole area is a posterior mediastinum. Posterior mediastinum, full parts, and this is the middle mediastinum, and this is the anterior mediastinum. Okay, so this space mediastinum is nothing but a space where in between two lungs. Okay, now the reasons. So what are the contents of this mediastinum? Superior mediastinum contains superior vena cava and the brachiocephalic veins, arch of aorta, thoracic duct. So all these structures, those are present in the below 3 mediastinum, has some parts that contains or the common in the superior mediastinum: trachea, esophagus, thymus, vagus nerve, left recurrent laryngeal nerve, which hook up the arch of the aorta, and the phrenic nerve. Now the anterior mediastinum contains, so this space contains thymus, lymph nodes, and the fats, and the middle mediastinum containing pericardium, heart. That is heart. I also already said that this middle portion contain heart and the pericardium, and the arch root and the arch esophagus vein and the main bronchi. And the posterior mediastinum, most important for surgeons, is the posterior mediastinum contains the great vessels and esophagus, thoracic aorta, esophagus vein, thoracic duct, vagus nerve, and the sympathetic nerve trunks and splanchnic nerve, that is parasympathetic portions. Gaiters, lesser splanchnic nerves, and the vagus nerve also, largest parasympathetic part, and these are the sympathetic portion. So if I make a cross section, so this is the anterior mediastinum, so this is the middle mediastinum, this is the posterior mediastinum. Okay, so here it is. This is superior, which only present up to the lumbar 4 and 5. So sorry, the thoracic 4 and 5 in between. there is a horizontal line which cross the second part of the sternal angle. It is also called the angle of Lewis. Now this sternal angle, first things, here it is the sternal angle. If I wrote down, so this is the sternal angle here. So what are the structures lie through this? So, and there are some importance, there is an importance of this angle. So if I say upper part of the mediastinum, that is this portion here, contains left brachiocephalic vein, brachiocephalic artery, left common carotid artery, left subclavian artery. These four important heart structures of great little lines just behind the manubrium sternum. So upper part of the manubrium, that's just behind it, left brachiocephalic vein, brachiocephalic artery, left common carotid artery, left subclavian artery. And the lower part, so here in this region, that is costal cartilage of the second ribs, transition point between the superior and inferior mediastinum. So transition, superior and inferior mediastinum. I already said that here, that this is the oblique line here above the superior mediastinum. This is the inferior mediastinum. Inferior mediastinum contains three parts: anterior, medial, and posterior. So arch of the aorta, lower part, tracheal bifurcation here occurs, union of azygous vein and superior vena cava, that is azygous vein just enters or drained into the superior vena cava in this level. Okay, azygous vein drains in the superior vena cava in this level, and the thoracic duct crosses the midline. Okay, I hope you understand these points, because in case of exam, there is a question like this, that underlying which structures is not present in the upper portion of the angle of Lewis. So Nietzsche, in which structure is not present or least likely to be present in the upper part of the manubrium sternum. So that is one of the important questions which is come from this point. Okay. Now the trachea. So trachea means respiratory tract. Okay, it is started from C6, that is cervical 6 vertebra, to the T5 vertebra bifurcations, and the anterior and venous supply, that is inferior thyroid arteries and the thyroid venous plexus. Okay, venous drainage from the thyroid venous plexus and the inferior thyroid arteries, nerve from the vagus and sympathetic and recurrent laryngeal nerves. Okay, so you must understand this inferior thyroid artery, which is supplied to the trachea and which is start from C6 to T5. Anterior relation, posterior and lateral relation. So here if you see here, this is the trachea, the ring like. So what are the structures like lateral on it, anterior and posterior part? So let's see. Anterior, above downwards, that is superior to inferior, isthmus of the thyroid gland, inferior thyroid veins, arterial thyroid edema, which is occasional, not always, and more superficially sternothyroid, sternohyoid, and cervical fascia, and anastomosis branches between the anterior jugular veins. Okay, so let's remember it. Anterior to the neck, isthmus, inferior thyroid vein, arterial thyroid edema if exist, sternothyroid, sternohyoid, cervical fascia, and anastomosis between anterior jugular veins. Posteriorly, esophagus, only one. Just remember this. Only esophagus lies posteriorly. Here you can see esophagus lies posterior to the trachea. And then laterally, there are some few vessels and nerves present. So laterally, so most common things is common carotid arteries. Okay. More commonly present common carotid arteries and the right and left lobe of the thyroid gland. Okay. So right and left lobe of the thyroid gland. and the inferior thyroid arteries and the recurrent laryngeal nerves. So you say laterally there are some few vessels and nerves. That is common carotid arteries in both sides is the great vessels, right and left lobe of the thyroid gland if thyroid is downward direction, or if thyroid is inwards, in that case lobe of the thyroid can be filled surrounding the trachea. Then then arteria inferior thyroid arteries, which is the branch of thyrocervical trunk of subclavian artery. Okay, now the relationship manubrium. So in so much anterior, that is manubrium, that remains thymus and aortic arch, and left common carotid arteries and deep cervical plexus. Laterally, superior mediastinum on the right side, pleura and right vagus, and the left side is the left recurrent laryngeal nerve and the aortic arch, left common carotid and subclavian arteries. So here the thyroid cartilage, the cricoid cartilage, and the see cricoid and thyroid. This is the whole thyroid gland. Now the esophagus. Esophagus is also called the food tract, okay, or food tube. So this is the long muscular tube just lying behind the trachea. So 25 centimeter long. First things first. Then started from the C6 vertebra, parts the diaphragm at T10 and ended in T11. That is 11th vertebra. So parts through the 10th diaphragmatic level and the ends in the thoracic 11. Lined by squamous epithelium, and the esophagus has no serosal covering. Must remember, there is no serosal covering, but also present adventitia. If you know what is adventitia and what is serosa, serosal lining placed where the potential body cavities or viscera are within the potential cavities, like peritoneal cavities, like pleural cavities, like peritoneal cavities. In that case, the viscera which lies within the potential body cavities, in case it is called the serosal covering. Okay. The orbus plexus and the meniscus plexus lies in between the longitudinal and circular muscle layers, and subcostally the submucosal location of the meniscus nerve plexus facilitates the sensory role. So orbus plexus and the meniscus lie between the longitudinal and circular muscles. So you must know these things. In case of FCPS exam, this kind of question sometimes seen. That is which of the nerve plexus maintains peristalsis. So orbus plexus or mesenteric plexus is the nerve plexus which also called the local nerve plexus maintain the peristaltic movements. The submucosal location of meniscus plexus facilitates sensory role. So meniscus plexus will on the submucous level will maintain the sensory role. So cricoid cartilage is incisor from the incisor sheath is 15 centimeter. The arch of the aorta 22.5 centimeters. The left principal bronchus is 27 centimeters, and the diaphragmatic heart is 40 centimeters. Oh, so what are those? That is a natural constrictions of the esophagus. So these are the points where malignancies are usually occurred. These are the junctions or constrictions where foreign body is easily obstructed or lost. Okay, so you must know in which level you are. You will find these constrictions like cricoid cartilage in the 15 centimeters, arch of the aorta is 22.5, left principal bronchus that is 27 centimeter, and the diaphragmatic height is 40 centimeters. Okay, anteriorly that is trachea to C4, recurrent laryngeal nerves, left bronchus and left atrium, and the diaphragm. Posteriorly that is thoracic T5 and hemiazygous T8, descending aorta and the first two intercostal branches of aorta, and the left side that is thoracic duct and the left subclavian artery. So these are the relationships. In the FCPS exam, relationship is very important, but in the MRCS it's not so important. Sometimes it is been seen that which is not present in the laterally, which may be present in the just anterior to the lower part of the esophagus, or structure lies above the upper half of the esophagus, just posteriorly, or least likely to be present here. So these kind of confusing questions sometimes asked in the MRCS, also in the FCPS exam. So right side, that is esophagus vein. Right side is the nothing else, esophagus vein. Left side is thoracic duct, and left subclavian artery. Okay, I hope it will be easier when you study alone by watching the long notes as well as the other notes. Okay, arterial, venous, and lymphatic drainage of the esophagus. So it is divided: the upper half, middle half, and the lower third. So upper third, middle third, and lower third. These three important divisions is usually divided by their characteristic changes. That is, upper third of the esophagus supplied by inferior third artery. Middle third is aortic branches, that is descending thoracic aorta, and lower third is by the left gastric artery. Vein is in corresponding inferior third vein. Middle portion is azygous vein, and the lower portion is left gastric vein. Lymphatic drainage is like that. That is, upper third is nearer the cervical region, so it is derived from deep cervical lymph nodes, and middle third is mediastinal lymph nodes, and the lower third is the gastric lymph nodes. And so the muscular layer, that is upper part, is voluntary, that is striated muscles, which is helps in deglutition, we all know that. And the middle third is smooth and straighted, and the lower part, that is smooth muscles, only smooth muscle, which is autonomic. So the nerve supply, upper half is supplied by the recurrent nerve, and the lower half is supplied by the esophageal plexus, that is vagus nerve. So both are vagus ultimately, but they are all supplies, that is parasympathetic. Okay, so which will enhance the peristalsis, okay, or propulse the movement of the esophagus so that food can go unidirectionally. So histologically, non-keratinized squamous epithelium. So it is the all through, that is middle part. Upper part is from striated, non-keratinized, but what is column that. So submucosa is a glandular tissue that has some few glands, which is the source of malignancy, which is the source of secreting mucus. And pathologically, these glandular tissue will form adenocarcinoma of the lower part of the esophagus, or middle part, or above, whatever you are, whatever we say. So muscularis adventitia, there is no serosa, but adventitia, I already said to you that there will be no serosa, but adventitia. Okay, so but adventitia, you must understand what I wanted to say, because in the previous, sometimes MS exam, it is in asked that in which following which viscerals don't have any serosal lining. So esophagus is one of them. Now the lung anatomy. The right lung is composed of three lobes, that is oblique and transverse fissures, which is the divisions containing. So right lung has two fissures, oblique and transverse, and three lobes. And the left lung has two lobes divided by the single oblique fissures. Apex of the lung is both approximately 4 cm superior to the sternocostal joints of the first rib. So above the first rib is 4 cm above. Immediately below this is a sulcus created by subclavian artery. So below this, the sulcus created by the subclavian artery. So peripheral contact point that of the diaphragm, the base is the diaphragm, because lung present just above the diaphragm. The costal surface corresponds to the cavity of the chest. Mediastinal surface contract, the mediastinal pleura has the cardiac impressions. And the above and behind this concavity, there is a triangular depression named hilum. Hilum is very important because it is the entry or exit point from to the lung. So the structure which forms the root of the lung and enters into the leave the viscera. These structures are invested by the pleura, which below the hilum behind the pericardial impressions form the pulmonary ligament. So pulmonary ligament has some another important clinical feature because it will help to expand the hilum, so that when or if there is any condition which can arise with increased venous return or increased blood supply, so this pulmonary ligament will expand to allow space to the great vessels like pulmonary artery and vein, and to expand by his own way. That's why pulmonary ligament is physiologically necessary, but there is no pathological indications. But if someone says, is it there is any pathology that maybe occurs there? Yes, in case of tuberculosis, Gun's complex, or if any malignancy spread to the hilar regional lymph nodes present here in the pulmonary ligament. There are some lymph nodes present here. In case of malignancy or in case of tuberculosis, there is a Gun's focus or lymphatic spread occurs just surrounding the pulmonary ligaments. Above the hilum, the ajagus vein superior to the groove is superior vena cava. On the right inner vein behind this, the nearer the apex, the furrow of the innominate artery behind the hilum, the attachment of the pulmonary ligament is vertically grooved esophagus. No need to here. So the root of the right lung lies behind the superior vena cava and the right atrium, and the below the ajagus vein. So if you see here the relationship around the hilum, that this is the left lobe, that left lobe contains the esophagus and the ajagus just behind, and the hilum, and there's some hilum structure. This is the hilum structures, and the part of the superior inferior vena cava and some supplemental vein and artery. And in the right side, so this is the right side. So in the left side, you see this arch of aorta and the part of esophagus, which is, this is the posterior mediastinum, so just behind the hilum. So both lung has the mediastinal surface relationship, because you must know that what are the structures is seen here in particular lung, because the like arch of aorta, the descending aorta is not present in the right side, but esophagus present in the both sides. Sometimes ajagus vein is not in the left side, but also in the right side present. So these are the common difference of like here there is no low arch of the aorta relationship, but here you see in the near the apex you can see the arch of aorta relationship here. So these are the things you must know during exam period, because you must be very cool and patient about what the question asks, because they will assess you about your anatomical knowledge, or yeah, either you can make the difference, you can hold the difference. Now, do you understand the difference or not? They will assess. With left up above the hilum, so you can see the phrenic nerve lies anterior to the mid hilum left lung. It is a fundamental things. The vagus lies posteriorly, and then arch is backward immediately. So backward immediately, posterior to the bronchus, give up the referent laryngeal nerves as it does so. Inferior border of the both lung as a sixth rib in the mid clavicular line, and the eighth rib in the mid axillary line, and the 10th rib in the posteriorly. So inferior border relationship from the very front, that is sixth rib in the mid clavicular, and the eighth rib in the mid axillary, and the 10th rib posteriorly. The pleura runs to, so no need. So this is the mediastinal, that is, if a lung is removed, then what is seen? Like this is the right side. You can see azagus vein, and the principal bronchus, pulmonary vein and arteries, and in the left side, you can see the cardiac areas along with the pulmonary veins, and um, two pulmonary veins and pulmonary artery and the bronchus. So this is the bronchus pulmonary segments, which has a pathological importance, because during lung carcinoma, if occurs in any lobe or any locations, lobectomy is usually done, because it is very easy to separate in each lobe. If you know the bronchopulmonary segment, you can resect the particular segments, micro segments from the lung. because that's why you must know the where the different kinds of bronchopulmonary segment lies. Okay, because these segments is unique by their vascularity, because it has individual bronchus, individual artery, but not in the vein, because sometimes one vein will give supply to the in right and left sides, in both sides lobe, micro lobes. So during lobectomy, just vein is blocked and artery and the bronchus is separate, so this can be easily resected. So the right side, that is the apical superior. So if there is a questions, in which lobe is usually foreign body is lost, because right sided apical segment of the lower lobe is the most common area where foreign body is usually lost, the apical segment of the lower lobe. That is it. Now the phrenic nerve has nerves, root values are cervical third, fourth and fifth, which keeps the diaphragm alive, because this is the main nerve supply which will control the diaphragm. Okay, so diaphragm sensation, central diaphragm and pericardium. And the phrenic nerve passes the internal jugular vein across the scalenus anterior. So this is the course, and the left crosses the anterior to the first part of the subclavian artery. So it comes forward to the subclavian artery, that is first part, and it passes with the internal jugular vein across the scalenus anterior muscle. In the right side, anterior to the scalenus anterior, crosses the second part of the subclavian artery. On the both sides, phrenic nerve lands posterior to the subclavian vein, posterior to the internal thoracic artery as it enters the thorax. So right and left phrenic, there are two branches in both sides. So it is superior mediastinum, anterior to the right vagus, and laterally superior vena cava. And the left side, it passes lateral to the left subclavian artery and aortic arch, left ventricles. Here it passes over the right atrium, exit the diaphragm at cervical thoracic 8, vena cava hiatus. So right phrenic nerve will go with the inferior vena cava through the vena cava opening in the thoracic 8 vertebra, but left phrenic nerve directly goes into the muscular part of the diaphragm. Okay, pierce the diaphragm direct. So here cervical third, fourth, fifth. So a nerve goes like artery, in between artery and veins, and goes downwards. So this is also, it goes downwards and supplies to the diaphragm. Now the thoracic ducts. This is the largest lymphatic ductal system of our body, which is continuation of the cisterna chyli of the abdomen. So is here, this is the cisterna chyli. Cisterna chyli is a dilated lymphatic channel which attached to the lumbar second and third, that is first and second. Here you can see the first and second lumbar body of the lumbar vertebra, it attached with it. So this is the continuation. So this is the greenish colored thoracic duct, which is started as a continuation of the cisterna chyli. Enters in the thorax by thoracic 12 vertebra along with the descending thoracic aorta. Lies within the posterior and superior mediastinum. So it will go through the posterior and superior mediastinum, passes to the opposite side from right to left side by in the level of thoracic 5. Lymphatic drainage of the left side of the head, neck, joint, thoracic duct prior to the insertion of the left brachiocephalic vein. So except the right upper half. So right upper half, except right upper half, all the body's lymphatic goes through the thoracic duct, except the right upper half, that is the right hand and the upper part of the chest and the part of the upper part of the chest, and the shoulder and the arm is not drained to the thoracic duct. Ultimately, it drains in between the left jugular vein and the left subclavian vein. In between here, it will enters. So ultimately, it will go through in between the left internal jugular vein and the subclavian vein, left side. Now the heart's anatomy. Heart anatomy is composed of, so heart is a hollow muscular organ. It has some muscular wall along with some tubular structures. The wall has a strong muscular arrangement, that is epicardium, myocardium and endocardium. There is three layers. So myocardium has important muscularity which will helps to contraction of the heart, and attached to the, so cardiac muscle attached to these cardiac fibrous skeleton. Okay. The heart and the root of the great vessels within the pericardial sac are related to the posterior aspect of the sternum, medial end of the third to fifth left in the costal cartilage. Pulmonary valve lies at the level of left third costal cartilage. You must remember this. And the mitral valve like the fourth costal cartilage. So mitral valve along with the fourth in the left side, and the in the pulmonary valve present in the left third. Okay, not fourth, but a little bit above. Coronary sinus lies posterior to part of the coronary groove and receives blood from cardiac veins. Okay, coronary sinus, which is the largest venous channel of the heart. Coronary sinus, the posterior part of the coronary groove, receives the blood from cardiac veins. And the great cardiac vein, middle cardiac vein, and great cardiac vein lies at the left, and the middle and the small cardiac vein lies on its right. So great cardiac vein lies along with the anterior ventricular groove, and the small and middle cardiac vein lies on his right side. Ultimately they drain to the coronary sinus. The smallest cardiac vein is anterior cardiac vein, drains directly to the right atrium. Okay, so smallest cardiac vein, that is anterior cardiac vein, that will not drain to the coronary sinus, but also that will drain directly in the right atrium along with some vena cordis minimi. There are some multiple vessels which also gives direct supply to the right atrium, anterior cardiac vein and the vena cordis minimi. So SEBI valve contain double leaflet. It's called the mitral valve. Mitral arrange wall is the trabeculae carni much thicker and more numerous, and the conocytes absence. Now the right coronary artery gives supply to the right atrium and the diaphragmatic part of the right ventricle. So right atrium and right diaphragmatic part, and the usually posterior third of the interventricular septum, and the sinoatrial node 60%. Must know an atrioventricular node is 80%. So sinoatrial node is 60%. It is very much most, and atrioventricular node is 80%. Okay, so very important. So left coronary artery supply left atrium, most left ventricles, part of the right ventricle, that is in the near the wall, and 2/3 of the left and interventricular septum, and the sinoatrial node is 40%. Innervation of the heart, autonomic nerve fibers from the superficial and deep cardiac reflexes. Okay, now the valve related topic. So what are the valve manners? So mitral valves have two cusps, which will indicate the first heart sound, and the anterior cusp, and attached to the chorda tendineae. Aortic valve has a three cusp, a tricuspid, second heart sound, it will show the second heart sound, and anterior two cusp, no chordae. Pulmonary also three cusp, second heart sound, and the two anterior cusp and no chordae. And the first heart sound mitral, it was also first heart sound, that is third cusp, that is tricuspid, that's why it's called, and the anterior cusp and the anterior chorda. So tricuspid valve and the mitral valve, that is connected with the ventricular structures, that is inner wall of the ventricle. There is a chorda tendineae, which contains ridge bridge papillary muscle. You say ridge bridge and papillary muscle, so which also called the chorda tendineae, which is attached to the cusp of the tricuspid and mitral valve. Okay, that's why it is called the chorda tendineae. But aortic valve and pulmonary valve, these are the seminal valves. Both valves has three cusps, and they will, if they stop or if they uh, stop the bleeding or the circulation, it will fail the second heart sound. Okay. Now the great vessel superior vena cava. Superior vena cava will give venous drainage to the heart from the head and neck, upper limb, and the thorax, and the part of the abdominal wall. And the formation, that is subclavian and the internal jugular vein united to form the right and left brachiocephalic vein. So ultimately both brachiocephalic vein will form superior vena cava. They united to form superior vena cava. Azygous vein joins the superior vena cava before enter the right atrium along the sternal angle. I already mentioned that. There are some four collateral venous system, that is azygous venous system, internal mammary venous pathway, and the long thoracic venous system, connection of the femoral and vertebral veins. Now the thoracic aorta. So now the great vessels aorta. So which is originated from T4, thoracic 4, along from the origin of the, or the starting from the sternal angle. Then the terminus is T12 in the thoracic 12 vertebra, then the abdominal portion. This is the thoracic aorta. So anteriorly, the root of the left lung and the left pericardium. Okay, left lung and pericardium. So anterior to the aorta, there is a pulmonary trunk. Okay, and the root of the left lung. Posteriorly, vertebral column and the azygous vein. Now the hemiazygous vein, right side hemiazygous vein and thoracic duct, and the left side left pleural lung. And the branches, the lateral segment branches posterior intercostal arteries, and the lateral viscera bronchial arteries supply bronchial wall and the lung, excluding the alveoli. Midline branches esophageal arteries gives supply from these thoracic aorta. Posterior intercostal arteries is also supplied from the aorta and the also the bronchial walls and lungs at least. Posterior heart valves and the chest wall. So where you will find the valve sound, that is first heart sound, second heart sound, because first heart sound complains along with the mitral and tricuspid valve. So this is the mitral valve here and the tricuspid valve here. So this is the mitral area and the aortic area, and this is the tricuspid area. So mitral and tricuspid area, in these two positions you will find, because here and here, these two things, these two things like second heart sound, and in these two there is the aortic and pulmonary area, and this is the oscillation of second heart sound. So tricuspid is usually medial to the fifth intercostal space, and the mitral is located behind, just middle to the left fourth intercostal space. So that is all about our today's presentations. I hope you like my channels. I hope you like my videos of MRCS study with me. So I hope you will keep continue and listening the videos, and you must go through the radar notes part 1 also. So to increase the time of study period, the things I relocated here or I usually emphasize here, you must go through each and every topic at least 2 to 3 times. Then you have to study EMRCS to know the pattern of questions, that what the questions are came from as the form factors. How? Because what kind of things they will ask from your study materials, because you know many things from the topics here, but if you don't know about the patterns of questions, it will be very difficult in that limited time period to answer the questions. So that's why go through the radar notes and practice EMRCS, and you must know recall, recall, and recall. Try to collect the recalls. Start EMRCS at least 3 to 4 times, then recall up to 2 to 3 times. to know the original answer and the explanation of the answers. You must know. So thank you very much for your patience watching, and I'm Dr. Asif Nawaz. Keep watching my videos. Fees. Thank you.